everyone. Now I'm thrilled to welcome back our ataxia expert, Dr. Susan Perlman. Dr. Perlman is the clinical professor of neurology and director of the Ataxia Center at the UCLA Medical Center in Los Angeles, California. Welcome, Dr. Perlman.
Thank you so much for inviting me back. And as I said, we're looking forward to this year being a productive year, hopefully matching last year. I know a year ago, January 2023, we were on tenterhooks as to whether the omaveloxolone drug for Friedreich's ataxia would be approved by the FDA. It was approved in February, and we now have many patients with Friedreich's who are taking it and showing some benefit. So I think that was a highlight of last year. And, you know, just with my own looking at the pipeline you have on the ataxia.org website and hearing from my other patients, some frustration or a little anxiety about the spinocerebellar ataxias, maybe not moving as quickly towards drug approval. But your pipeline is full with some very good industry-sponsored trials, and hopefully we'll see those successes this year. And I know the non-genetic ataxias, with the exception of multiple system atrophy, haven't really had any directed therapies on the pipeline. But at least multiple system atrophy will probably have 3 or 4 active trials going on in the United States this year. So it's going to be a busy and hopefully productive year, and hopefully we'll have some updates at later sessions. So looking at the questions that are coming in, a question about anesthesia drugs used for somebody who might require a surgery, and this is a particular individual with spinocerebellar ataxia type 6, had propofol and metemizole during surgery, and apparently ataxia symptoms did get worse, but only temporary. I think it's fairly common after any sedating procedure, certainly a general anesthetic procedure, or even you know, one that is even moderately sedating, that the cerebellum is not going to perform as well, that there is going to be a temporary worsening of symptoms that may require a longer stay in the recovery room, for instance. The use of lidocaine and paracetamol are not known to worsen symptoms of ataxia, and if your surgeons and anesthesiologists feel that those will be enough for your next planned surgery, you know, I would pursue that. Matthew Lombardi, does cannabis have any negative effects specific to ataxia? I think most recreational drugs or drugs in that family, you know, cannabis is sort of on the border between recreational and medical, may worsen symptoms. You know, they tend to, you know, affect the cognitive areas of the brain. You know, they can give you a high, which could have a negative effect on balance and coordination. Many patients with ataxia may use cannabis-related substances at night to help sleep, to reduce, you know, leg spasms during sleep. So if you're planning on trying cannabis, do it safely at a time when you know, if you're experiencing negative side effects, you won't have to go out and do anything for a little while. Tomer Hillel is asking about high-intensity interval training versus moderate activity for spinocerebellar ataxia type 3. I know that there is interest in doing a study of high-intensity interval training versus regular therapy that could have some cardio, could have some core strengthening and other things, but without the high-intensity intervals. So we don't know which approach is going to be better, but some exercise always helps. And I think the only limitation with high intensity interval might be fatigability, or if you're having, you know, muscle or joint pain and you overstress yourself. But there is ongoing research in the rehab community looking at appropriate exercise programs for ataxia. Now, here's somebody reminding me that in our last Q&A, I had talked about reserve. And that's typically in the brain, average brain, aging brain, we have reserve so that if we are active, overdo a little bit, certain pathways may fatigue or tire, but other pathways, neuromuscular pathways, even brain pathways could kick in. So somebody who's had a stroke, for instance, they can, through rehab, retrain the unaffected parts of the brain, the reserve, as it were, to come in and take over some of the functions that were compromised by the stroke. So can one build their reserve back with various activities? I think a good example of this is polio survivors or survivors of spinal cord injury, where with good rehab, they seem to be able to get their reserve nerve pathways to reattach to some of the orphaned pathways, whether it's muscle or spinal pathways, to bring signal back to those areas. However, with aging, it's generally recognized that normal aging, by the time you're 80, your reserve capacity to heal, to kick in, to take over is reduced. And if you have lost, let's say, upwards of 20% of a particular brain area or brain pathway, you effectively have no reserve in that pathway. So it is possible to build reserve, but at some point, the reserve may be exhausted. So, Nuno Gallego, do you know something about Selos? Selos is on pause. This is the intravenous trehalose study, which is supposed to act as a protein busting agent to break up the protein aggregates that are building up from the mutated gene. And there's a trial of oral trehalose, fairly high dose, that's going on, I believe, in Thailand. But it's felt that the intravenous, you can get by with a lower dose, more of the active trehalose compound will get where it needs to go in the brain, for instance. So, their initial study, a phase 1/2 study that was done a number of years ago, did show stabilization of ataxia over the course of a year. There were treatments, and then the disease seemed to stabilize and not progress. I don't remember from that initial study if there was improvement. So the current Selos study is on pause. People were enrolled in it, but the company is currently pausing enrollment. And I understand they have some promising early data from those initial participants. And we'll have to see where this study goes, if they can reopen for a larger and ongoing study. Now, Linda McKee has a question: is spinocerebellar ataxia similar to MS? Family members have both spinocerebellar ataxia and other MS. Now, I have seen 2 SCA3 families where in each family there was at least one family member who had multiple sclerosis and also had spinocerebellar ataxia type 3. MS is relatively common in certain individuals, certain age groups, certain geographic areas. So just by the throw of the dice, as it were, a SCA3 family is not immune from MS appearing. The symptoms can be similar. And prior to the availability of genetic testing, I know in at least one of those SCA3 families, we were convinced that the individual had SCA3. Symptoms were very similar to other family members. But when the genetic testing came available, his test was negative for SCA3, and he clearly had MS. So I think it's important to recognize in a genetic ataxia family that you're not immune from other disorders. And genetic confirmation of the genetic disorder is important, but also testing to look for other conditions that could, occur concurrently. And like I say, I've seen this in SCA families. I've also seen it in Friedreich's ataxia, where somebody has Friedreich's and they also have MS. So it's a good thing to be alert to. Okay, Carolyn Howell, what are the key palliative steps for an elderly woman with multiple system atrophy? So we're talking about palliative. And I'm getting an implication here that this person, being an older person, may feel they don't qualify for active clinical trials. And as I said, there's going to be at least 3 or 4. There's currently 2 trials running, and there's another 2 that will be starting up specifically for multiple system atrophy or multiple system ataxia. But I think, the key non-disease modifying things that everybody with ataxia should do: fall prevention, choking prevention, and monitoring sleep. Since with sleep disorders, which can occur in any of the ataxias, including MSA, will sap you of energy and impair your daytime performance. And in some cases, if you're having snoring or sleep apneas, breathing can be compromised at night. So if we're paying attention to fall prevention, to adequate nutrition without choking, and to safe sleep, I think you can carry on with a progressive ataxia relatively comfortably. Now, multiple system atrophy may involve other things besides the nervous system. There can be blood pressure instability, there can be problems with heart rhythm, there can be bowel and bladder issues. And these, in general, there are good ways to manage them. Our medical colleagues outside of neurology, have very good strategies for stabilizing heart, stabilizing blood pressure, working with bowel and bladder dysfunction. So, you need a team, and you need to be aware so that you can track, any area that you're having problems with and make sure that your concerns are answered. Now, Nuno Gallego has a question about transcranial magnetic stimulation. There has been at least 1 or 2 studies done with the use of magnets, applied to various parts of the head to stimulate electrical activity in pathways that control balance and coordination, for instance. TMS is already approved for the treatment of depression, especially depression that has been resistant to medication. And like I say, there's been a couple of studies about its use for ataxia, suggesting that it could be symptomatically beneficial, but it's currently not available for clinical use outside of a research study. Mary Gatch is asking, what is the status of the FDA review of troriluzole? Now, remember, we can only talk about things that are public knowledge. We know that troriluzole has had 5, 6, or more years of use in controlled trial settings, that the most recent trial found the most prominent evidence of benefit in spinocerebellar ataxia type 3, and that data package was prepared for the FDA. However, as we all know, the FDA did not want to look at it. And I have no idea why. I would imagine that one area that the FDA may have wanted to have seen is not just the SCA3 data from the trial, but all the SCAs that participated in the trial. They may have wanted to see some longer term data, which has been collected and prepared. And I know that sometime this year, in the early part of this year, Biohaven will be meeting with the FDA to go over their current data package and hopefully move it into review. So, we'll be waiting to hear over the next month or 2 about that. Now, here's an anonymous attendee who's 74 years old, has a genetically confirmed SCA3 10 years ago, unfortunately was hospitalized and was found to have had a seizure. Now, seizures in adults with spinocerebellar ataxia type 3 are not common. In the genetic ataxias with very, very early onset, in childhood or infancy, the whole brain can be affected, not just the cerebellum, and seizures could occur. And with spinocerebellar ataxia type 10, seizures can occur in certain families. The ataxia type 3, it's unusual, but now this individual is on anti-seizure medication. So, number one, we want to make sure that the anti-seizure medication is controlling the seizures, which themselves could be dangerous, could lead to falls or other things that would worsen your SCA3 progress. But as far as I know, in adults with SCA3, seizures are not known to be directly related. And in an older person, the most common cause of seizures is a stroke, a small stroke that may not have had any lingering motor effects, but could have triggered a seizure or some type of head injury. Now, Danielle Bashara is asking, do I feel that cerebrolysin is effective? I don't know. So this is a question, as I always promise, ones that I don't know the answer immediately, or would have to quickly go back to the literature and check. I've heard of cerebrolysin, but I'm going to have to go back and look. And I asked Lori Sjogren to remind me about the questions that I'm going to look up when we get done, and then get back to her so she can share what I've been able to find. Diane Cast has two questions. Have I worked with SCA patients whose disease cause was Agent Orange? If so, does that disease progress similar to genetic-based SCA patients? Now, any toxin-related ataxia, whether it's mercury, Agent Orange, I've seen, I think, a couple of people over the course of my working in the ataxia clinic who were exposed to Agent Orange. There are industrial toxins that have been connected with ataxia. More often than not, the toxic exposures, if they are significant enough, will cause disease progression that is a little faster than the genetic ataxias. But it depends on the amount of exposure. Somebody with severe mercury exposure, could have a severe ataxia that develops fairly quickly. So I think it's important, to note that someone may have had an Agent Orange exposure, to look at other potential environmental exposures, but also to recognize that there could be genetic factors that sensitize that individual to, industrial toxins or pesticides or whatever the exposure was. So even if you're convinced, no family history, not obviously genetic, I do have a toxic exposure, I would pursue at least some genetic workup, looking for a possible underlying genetic factor with your treating physician. And then the current research outlook, if we go to the ataxia.org website, look at their research pipelines, the Friedreich's ataxia pipeline is packed with drugs that are getting ready for clinical trials, drugs that are in small trials, drugs that are in FDA registered trials. The spinocerebellar ataxia pipelines are shorter, smaller. Only a couple of drugs have entered human trials. I think the most promising approach beyond neuroprotective strategies like Biohaven's drug or symptomatic medications, which are still being developed to try to help symptoms of ataxia or tremor, are the gene blocking agents. And there are a number of companies working on ways to prevent the triplet repeat disorders, which are the common SCAs, from producing the abnormal protein that then has gain of function or toxic effects. Ionis has been developing a library of these agents for most of the common spinocerebellar ataxias. They had planned a trial together with Biogen for SCA3 that has been sort of put on hold, I think, because of safety concerns, which are being worked out. There was a trial for spinocerebellar ataxia type 1 that seems also to be pausing, probably because of similar safety concerns. And these, I believe, are based on the experience in Huntington's disease with gene blocking agents of that type, where a certain dose range seemed to be safe and effective in people with early disease, but a higher dose range did have some unexpected, pretty severe side effects. Now, Vico, currently based in Belgium, is running a trial of gene blockers, as they were referred to, in ataxia type 1, Huntington's disease, and also a splicing modifier, which effectively splices out the mutation to again produce a normal protein only for ataxia type 3. They're in a phase 1. We're hoping to see them come to the United States with an FDA IND authorization to open up a phase 2 trial that will involve the US as well. The current European sites, there are 2 sites in Germany, 1 in Paris, and 2 in the Netherlands. And so we should, be eagerly awaiting the results of their phase 1 trial. But I think everybody in the SCA, network is a little frustrated about all the good ideas that we have from the basic science research going on and how hard it is to get an agent across the finish line into a human trial. So we just have to keep supporting, these industry-related groups, supporting the labs, and supporting the investigators as much as we can. So Mary has another question here about, cerebral lysine, which I'm going to have to, look up, so I can't really answer that. Buspar is an older drug that was felt to have symptomatic benefit based on serotonin pathways in ataxia. It's also an anti-anxiety agent. And then NV-291, which is ringing a bell, and again, I'm going to have to look it up. But there have been published trials of Buspar. Some positive, most of them not showing major benefit. And then cerebral lysine and NV-291, like I say, I'm going to have to get back to you on that. So Jean Laforgia, is there any connection between SCA8, pernicious anemia, and fatty acid metabolic disorder? This individual has been diagnosed with all 3 in the past year. Okay, SCA8 is not known to have any metabolic issues. Pernicious anemia does relate to B12 deficiency and typically with difficulty absorbing B12 from the diet, which could have a genetic basis, but it is different from SCA8. And then fatty acid metabolic disorder, which I'm going to have to look up, again suggests a problem with the metabolism of fatty acids, which is associated with a handful of fairly common disorders. Adrenomyeloneuropathy, adrenoleukodystrophy is a metabolic problem affecting very long-chain fatty acids. And I'm sure that there are others. Most of the pretty severe inborn errors of metabolism will begin having symptoms in childhood, but can occur in adults if they are milder. Pernicious anemia can occur pretty much at any age. And, I think, this individual, probably, has the unfortunate distinction of having 3 relatively rare conditions. And I am not aware of any association, except all of them can affect the cerebellum, so that symptoms of ataxia might be more bothersome, more severe, harder to manage with the triple header going on there. Stephen Bates asks, is ataxia considered to be both a condition and a disease? Yes. Ataxia is a symptom that can be caused by dysfunction in the cerebellum, can be caused by dysfunction in pathways leaving or entering the cerebellum, can be caused by inner ear problems, vestibular problems, or can be caused by problems with decreased sensation in the legs and feet. So ataxia as a symptomatic condition, you could see on exam, your doctor will look at your walking is unsteady, it's veering, it has a wider base, but they won't know the cause without doing further testing. There are ataxias that are recognized diseases, and these are typically the genetic cerebellar disorders. So this individual, Stephen, has an acquired ataxia due to a pontine stroke. And this is a symptomatic condition because the outgoing fibers and incoming fibers from, and to the cerebellum do pass through the pons. So, if those pathways have been interrupted, the cerebellum is not going to function well. There are other genetic forms of ataxia which we know of, and these are the ones that are considered specific disease entities. So Mary has another question. Have I seen any patients who improve in taking taltierolin? I have had probably 3 patients over all these years who have been able to obtain taltierolin. At least one of them had a genetic ataxia, one of them had a non-genetic ataxia. They felt better on it. They felt more stable on it. It was approved as an ataxia drug in Japan because of research that was done there. Thyrotropin releasing factor type agent. We have not done an FDA-sponsored trial here in the United States. So the difficulty in getting taltierolin is that you have to present yourself in person to a prescribing physician in Japan, and you have to, you're not going to get refills mailed to you. You have to show up periodically to get a new prescription. And this is what I've heard from patients who have pursued it. There was no correlation I could see between any thyroid disease. So I think the impact of thyrotropin releasing factor, which is what taltierolin mimics the activity of, is probably having an impact not on the thyroid, not influencing the thyroid in people who are taking it, but probably some other target that I think is, I would have to again look it up to see what we've discovered about that. Ronald, just before losing my balance, my eyes and my feet do not seem to be working together. Why is this and what can I do about it? So if you have a cerebellar ataxia that could be causing eye incoordination, nystagmus, problems with, making both eyes, work together so you can judge distances. And if your foot coordination is not reliable, you know where you want to move your feet, but the feet end up going in a different direction, again, because of the cerebellar changes. The eyes and the feet do both work together with the cerebellum, so that, what you see in your environment gives signals to the cerebellum. The cerebellum knows that you want to move your feet, and it can help coordinate foot movement. If the cerebellum is defective, number one, this communication, eye-foot coordination, eye-hand coordination is going to be interrupted at the level of the cerebellum. If you're getting the wrong signals from the eyes because of nystagmus, if you have ataxia affecting upright stability and your feet, then the necessary eye-foot coordination, eye-hand coordination is going to be getting the wrong information and will not work together, as you pointed out. So the normal way this is approached, if we can manage symptomatically the signals from the cerebellum, can we improve them so the feet will respond a little better, the eyes will respond a little better. There are medications that are used to stabilize eye coordination and also upright stability and foot coordination. Physical therapy, rhythmic repetitive exercise that works on eye coordination. In fact, if some of you have worked with a physical therapist who had you walking down the hall while you're turning your head, that is trying to engage the eyes with the rest of the walking pathway, and practice helps. So any exercise program that works on eye-foot coordination or tries to make the cerebellar signal stronger is going to help that and reduce the risk of falling. Can Seroquel used for 5 or more years cause permanent ataxia after it's been discontinued? I would say no. I do not know that Seroquel has that long-lasting effect, although that category of drugs, quetiapine, Seroquel, there are others that are stronger, are known to affect motor pathways. They can lead to fidgetiness, they can lead to stiffness, and the fine print is, side effects of drowsiness, incoordination, etc. But once the drug is discontinued, for the most part, those side effects will go away. there are a handful of drugs that are known to cause damage to the cerebellum. Dilantin is notorious, and I think there's, a couple of other drugs that are known to not just cause symptomatic worsening, but, actually to damage the cerebellum. So Seroquel, while, that family of drugs may cause some changes in motor capabilities, I am not aware that it could cause permanent ataxia. And if Lori will make a note about that, I'll go back to the literature and confirm that impression. So Elise has a question, wishing us all Happy New Year. Any exciting update on trials for omaveloxolone or Skyclarys with children? Now, Elise, if you've been following the chat on the Friedreich's Ataxia parents group, Paul Conance has been updating us. Juan Carlos has been giving updates about this as well. And Dr. Lynch has been, monitoring this too. He was initially going to sponsor at Children's Hospital of Philadelphia a phase 1 type trial looking at dosing and side effects in children. But the drug company that owns the drug, Reata, has been acquired by Biogen, and they are planning a more extensive trial, beginning with older children and then going to younger and younger age groups, that is anticipated to start this year and ultimately get to the youngest children by the end of the year. And again, it's primarily going to be looking at dosing and side effects. And obviously, over a 3 to 6 month span, there could be measurable good effects as well. So that, I think we can look forward to in this calendar year. And any exciting or promising updates on DNA repair or gene therapy ongoing? So in Friedreich's ataxia, there are 2 trials and a 3rd trial that is beginning with gene transplant for the cardiac disease, the heart disease that can affect children with Friedreich's. So they have a gene replacement that will go to the heart and ostensibly allow the heart to make frataxin protein, which will then support, the metabolism and action of the heart muscle and nerve pathways. Regarding Friedreich's, similar approaches to getting a replacement gene into the brain have not yet moved into human trials. However, I know one question that always comes up is CRISPR. And I know there's been work with CRISPR in a variety of disorders where you can snip out the mutation, which I think is easier to do systemically, with a tissue, a blood-based tissue that is constantly reproducing itself. But using CRISPR in the brain, where the brain cells are what you have, they're not going to reproduce themselves. Potentially there's stem cells there that could participate in healing. Maybe you could CRISPR them so that they would heal and grow in normally without the mutation. But I think the more promising areas are, 2 groups that are working on splicing modification, that when the DNA makes RNA and then the RNA makes protein. So typically you have a mutation in the DNA, a triplet repeat mutation is the common one we know about. It makes a messenger RNA that has an abnormal segment in it. And then that messenger RNA makes protein that has an abnormal expanded segment, which is toxic. So there are 2 groups working on what are called splicing modifiers, so that when the mutant gene is making messenger RNA, then the messenger RNA is modified so that it's prepared to make protein. During that modification process, there are drugs, approaches that can alter the splicing of the conversion of the messenger RNA from raw messenger RNA to functioning messenger RNA that eliminate the mutation. So you end up with a piece of messenger RNA without the mutation. It's a little shorter. It makes a protein that's a little shorter, but that protein appears to do its normal job. And SCA3 has two companies, PTC Therapeutics here in the United States is working on Huntington's disease splicing modifier, and SCA3 I think is next in their pipeline. Vico in Belgium, in Europe, already has a phase 1 trial going with a drug for SCA3 that acts as a splicing modifier. So I think being able to, manipulate, the gene product, usually through the RNA, replacing the gene in disorders where, the gene is non-functional, as it is in Friedreich's, are technologies that are growing in the last 10 years. So I think, certainly for Friedreich's and, for the splicing modifiers for the adult ataxias, we can keep an eye out for that. Teresa is asking, are there any new treatments for episodic ataxia type 2 in the works? Not that I'm aware of. We know that acetazolamide, can be effective at suppressing the episodes of ataxia. We know that dalfampridine, which, was approved for multiple sclerosis, has been used as a way to suppress attacks of ataxia. And either one is a good choice for somebody who has genetically determined episodic ataxia. But, whether there are other drugs that could be symptomatically beneficial or gene therapies to modify the mutation in the gene, I don't know. So again, it's going to go on Lori's list, and I'll do a little homework and get back to you on that. Scott has a question. Does ataxia affect hearing? Some of the ataxias do affect the nerves that control hearing. So the mitochondrially mediated ataxias, any organ in the body that needs a constant supply of energy, if you have a problem in mitochondria, it's going to make it hard for the cerebellum to function properly. It's going to make it hard for the heart to function properly. And as we know from looking at mitochondrial diseases, and there are many that have been well described, some of them do have hearing loss. And in Friedreich's ataxia in the later stages, there can be hearing loss. So if there is a cerebellar problem that has a heart problem associated with it, a hearing loss associated with it, as just two additional factors, or anything outside of the actual nervous system, somebody should be screened for mitochondrial dysfunction. I am not aware that any of the commonly described ataxias are directly associated with hearing loss, beyond Friedreich's ataxia and the mitochondrially connected ones. But again, Lori, make a note. I'm going to go back and check the literature on that. So Mary has a question about mesenchymal stem cells versus other types of stem cells and autoimmune illnesses. Okay, so autoimmune illnesses, we know the body can make antibodies that are misdirected and can attack the cerebellum. GAD antibodies do it, antibodies associated with underlying cancers, antibodies, and there are others as well. So that somebody who presents with a apparently non-genetic ataxia should be screened for bad antibodies, as it were. Then stem cells have been used to treat a variety of illnesses. It's recognized in the nervous system that exposure to stem cells can stimulate nerve growth factors, which can help neural pathways that are under some type of stress. There was a stroke or an injury or a genetic stressor, that stimulating nerve growth factors can help restore reserve, as we talked about earlier. So that, there's, been some work, in a couple of companies, the StemInent company I'm most familiar with, using stem cells in genetic ataxia. There's been work in South Korea and at the Mayo Clinic using stem cells in non-genetic ataxia. again, to try to stimulate nerve growth factors and stimulate nerve regrowth. The stem cells do not grow in to replace missing nerve cells. What they enable the brain to do is to draw on reserve. So have I ever seen regeneration of cerebellar cells and an improvement in balance? I have one personal exposure to stem cells for genetic ataxia where it wasn't clear that there was a benefit. And, an N of 1 study is hard to interpret. I've seen data from, some stem cell studies, and I think some of that data has been published, suggesting that there could be some improvement or some stabilization relative to what would be expected over a longer period of time with that particular disorder. So I think the stem cell approach is still active in research, but people who travel to other countries, China being notorious, to receive a month of stem cell treatments, usually those treatments are accompanied by acupuncture, vigorous physical therapy, other interventions that could provide short-term benefit. And I did have a couple of patients who traveled to China for stem cells for ataxia, who, they came through Los Angeles on their way. I met them before they went to the airport. They came back through Los Angeles on their way home. I met them as they got off the plane, as it were. They did seem better. But after about 3 months, the benefits kind of declined. And I'm wondering if they were experiencing the benefit of vigorous physical therapy rather than the actual, ongoing stem cell benefit. So, I think if you wish to participate in a controlled research trial of stem cells, it's not unreasonable to do, but I would not mortgage the house to go, to some commercial stem cell group for a series of treatments which have not been fully studied. On the other hand, autoimmune diseases, you can treat them with intravenous immunoglobulin. You can treat them with other immunosuppressive agents. If there's a source for the bad antibody, an underlying cancer, you can treat the underlying cancer and reduce the autoantibody that is being produced. And I have seen people with clear antibody-mediated ataxia who pursue one of these lines of therapy, usually IVIG, who do improve and stabilize over a long period of time. So, certainly, there are treatments that have been used for years now. IVIG has been around for a long time. Stem cells have been studied for a number of years that, we need to keep our eye on. Now, here's an anonymous attendee who's asking, should I avoid alcohol altogether? I don't drink much, but I do enjoy a glass of wine infrequently. So there's 2 things about alcohol consumption, 3 things actually. One is that, the effects of alcohol on the brain could worsen symptoms of ataxia. Constant drinking without a break, daily drinking of moderate amounts of alcohol can weaken the nervous system, can lead to peripheral neuropathy, which will make your balance worse, and can also target the cerebellum, potentially in people who are at risk for that. But, daily alcohol intake is known to be a risk factor for cerebellar ataxia. So I think if you're drinking a small amount of alcohol infrequently, where there's at least a day or 2 between, glasses that you are consuming, you might notice that you're more likely to get off balance, during the time you're consuming it, but you won't have accumulated any new damage. Now, with, there's a literature out there, by patients and families where, they've gone to the point where they try to avoid alcohol in any form. Some cold medicines and some other over-the-counter medicines have alcohol in them. And, there were people generating lists of brands to avoid because they have alcohol in them. But, I think, we know that alcohol can be symptomatically problematic, just like, anesthetic drugs may be symptomatically problematic, just like, marijuana can be symptomatically problematic. but used judiciously and avoiding falling, there shouldn't be any accumulation of long-term problems. Another anonymous attendee, can I provide an update on where troriluzole is currently? And I think we addressed that already. Tammy mentions many of my family members have an adult onset dominantly inherited form of ataxia that presents with muscle spasticity, gait disturbance, slurred speech, etc., but no cerebellar atrophy on MRI. And this suggests that the symptoms of gait disturbance, muscle spasticity, slurred speech are probably not coming from the cerebellum, but potentially from brainstem and spinal cord changes, which, as in Friedreich's ataxia, cerebellar atrophy ultimately appears, but in the first 15 to 20 years of illness, the cerebellum looks normal because it's the spinal pathways that are affected. Now, this individual had the GeneDx genome sequencing test, the Dante Labs rare disease panel, and Centogene's whole exome testing done, all with negative results. Do these cover every possible test, or is there another test my family can do, such as repeat expansion test, or a specific test, for SCA27B, which is an expansion? Without a positive test, what medication would we recommend? So exome sequencing will not reveal expansions. So if there's a segment of the gene that is too big, has a stutter in it, it's too big, and then makes a protein that has a defect in it or is too big, that will not show up on whole exome sequencing. And expansion testing needs to be done, either a panel, a specific test for SCA27B, which is becoming more commonly identified now. So definitely I would pursue expansion testing. And currently the only lab in the United States that's doing testing for SCA27B is the University of Chicago. So that would have to be sent specially to them. They will also do the repeat expansion testing. It's part of the same panel. And without a positive genetic test, what medication would I recommend? First of all, if you have a genetic risk that has not been identified yet, but it seems to be contributing to ataxia and spasticity, rehabilitation, physical therapy, a good home exercise program is key. Everybody should be doing that, not only to control symptoms, to try to retrain the nerves to behave better, to reduce tightness in the neuromuscular pathways, but we know that rhythmic repetitive exercise, aerobic type exercise, can increase nerve growth factors in the brain, at least in the mice. So that could potentially slow progression. Antioxidant vitamins and supplements, they've been around for a long time. Anti-aging supplements, anything that's recommended for, the frail elderly, people with genetic disorders are looking at and wanting to try. There's no evidence that vitamin E, CoQ10, idebenone, fish oil do anything to slow progression of genetic ataxia. However, symptomatically, they may help with fatigability. They may help with muscle pain. Vitamin E can do that. So, I think if you're planning on using an over-the-counter or nutritional supplement, investigate it carefully, because some of them do have side effects. Now, for symptoms of ataxia, for people who are ataxic, even though there's no positive test, the American Academy of Neurology recognizes 2 drugs that can be used off-label. They're approved for something else, but they can be used off-label for ataxia. One is regular riluzole, which is approved for Lou Gehrig's disease, but has European studies, at least 2 studies, that have shown benefit for symptoms of ataxia and possibly slowing progression of ataxia. And the other is dalfampridine, which was approved under the brand name Ampera for multiple sclerosis, gait-related problems. It has a track record of being somewhat helpful for dizziness. It seems to be helpful for ataxia, and it does have, some evidence of being helpful for muscle spasticity. So, I think for somebody who is symptomatic, if they wanted to try a symptomatic drug, riluzole or dalfampridine would be reasonable to try. You can get them by prescription if your insurance doesn't cover them because you don't have ALS or you don't have MS. With a good RX coupon, you can get them at a pretty decent discount. If you have other symptoms going on, from spasticity, if muscle spasticity is a truly limiting factor, there are several anti-spasticity agents that could be used. Baclofen, tizanidine are two of them. If you have tremor complicating your ataxia, there's many tremor-related drugs that could be tried. And even for nystagmus, there are medicines that can help stabilize nystagmus. So symptomatic benefits, can be achieved. Disease-modifying benefits, like I say, the research is still going on. And if you can identify the gene in your family, it can open you up to research participation. Michelle has a question. Her brother-in-law was recently diagnosed with an acquired ataxia due to viral meningitis. They were given limited diagnostic information and he's completely immobile. Will go back and forth, being able to speak and move his limbs a little bit to hardly at all. They just want some answers and want some direction on where to reach out to get someone to look at his case to see what else we can do. So if there was a viral meningitis that damaged the cerebellum, depends how recently that damage occurred. Natural healing with good rehab can often restore some better, more reliable performance than you have pointed out. So I'm hoping that if we are within a couple of years of this event, that your brother-in-law has been doing aggressive physical therapy, occupational therapy, speech therapy, to try to stimulate those areas. If there is a lot of damage and not enough reserve to really effectively respond, then we're looking at symptomatic medication. Now, for people with brain damage, from, a viral meningitis, was the damage just in the posterior fossa, the cerebellum? Did it affect the entire brain? I have seen people with head injury who have benefited from carbidopa-levodopa, which is a drug that is used for Parkinson's disease, but it seems to have a stimulating effect on people who have had closed head trauma or brain damage from a variety of causes. And if this is an older viral meningitis, damage to the brain, potentially more than just the cerebellum, might be worth a trial of carbidopa-levodopa to see if we can activate some of those pathways. So if it's a stable defect, more than a year or two ago, you should be able to get good counseling from somebody who deals with brain injury. Whether it's traumatic brain injury, I mean, this is a stable brain injury. They see people with stroke-related brain injury. So, I think that could be a good clinician to begin with. Now, Sylvia is contacting us from Poland. Is there any planned work on a drug for GAD65 ataxia? Plasmapheresis is ineffective. So GAD65 is an abnormal antibody that cross-reacts with the cerebellum, causes ataxia. It is sometimes associated with lung tumors, but can occur with no obvious underlying cancer. If we look at the literature, treatments to suppress the levels of the antibody, plasmapheresis filters out the antibody. IVIG dilutes the antibody, so that if all you've tried is plasmapheresis and you haven't tried IVIG or Rituxan, which is an immunosuppressant that selectively suppresses antibody production but doesn't interfere with the rest of the immune system, I think those are two approaches that could be helpful. Now, the drug that was recently approved for Friedreich's works on the mitochondria. So if, it's not known that GAD65 ataxia impacts the mitochondria, so it's not clear that that drug would be helpful. And GAD65 ataxia isn't in the numbered series. The numbered series, SCA 1, 2, 3, 6, all the way up to SCA 50 now, are genetic disorders, while GAD65 is a non-genetic acquired ataxia. So definitely speak to your physician about intravenous immunoglobulin, IVIG, or a trial of Rituxan. And again, rehab physical therapy is important for any form of ataxia. Here's an anonymous attendee, and I think we have time for maybe one more question. The time just flew here. I have heard that the gene mutation causing SCA4 was recently discovered. What do I know about this? It was reported. It's associated with a genetic factor that causes a sensory ataxia. And beyond that, I'm going to have to go back to the literature and see where that's going regarding, potential disease modifying interventions. Okay, and do I prescribe chlorzoxazone for nystagmus? I really don't prescribe chlorzoxazone for anything, but the National Ataxia Foundation has a long list of medications that have been used for nystagmus on their website. So I think we may have to stop here, and I'm sorry we couldn't get through more questions. I'm seeing some familiar names here, so hello to people that I have seen or maybe haven't seen in a while, and looking forward to the upcoming National Ataxia Foundation convention in May, so I can hopefully get to meet more of you. So we'll leave it at that. And
Thank you
Lori
so
has
much,
promised to
Dr.
get
Perlman.
me those questions that I couldn't finish answering so that I can look them up.
Yes, I took very detailed notes of all of those things that you called out. So we had over 150 great questions asked today. So as Dr. Perlman said, we have our conference coming up. So I hope everyone takes an opportunity to register for the upcoming conference where a lot of questions can be answered there. Also, if you didn't get your questions answered here today, please plan on attending some more of our Ask the Expert sessions later on in the year. So thank you all for, again, asking so many great questions this session, and Dr. Perlman for offering so much great responses to the questions. And Dr. Perlman will follow up with those that she said that she's going to follow up with. And I will send the notes to you, Dr. Perlman. And
Thank you.
just wanted to let people know, if you want to refer back to any thing that was covered in today's session, a recording will be made available on NAF's website and YouTube channel. So thanks again, everyone. We'll look forward to seeing you in May at the conference and at future Ask the Expert sessions. Have a great day, everyone.